Welcome to the NeoFOCUS-UK Education Group webinar series.
I'm going to introduce our speaker who, as I said, we're very, very thankful for not only coming 2 weeks ago to moderate, but also, again, getting up early in order to present to us today what will be a fantastic talk on ductal dynamics in congenital diaphragmatic hernia. So Dr. Gopal serves as an assistant professor and consultant in neonatal perinatal medicine at SSM, Health Cardinal Glenning Children's Hospital and at St. Louis University, specialising in the management of congenital diaphragmatic hernia. Her research focuses on CDH hemodynamics, biomarkers, and the use of minimally invasive techniques to predict outcomes in CDH cases. And Dr. Gopal is engaged in both national and international collaborations on various CDH projects and participates actively in several focus groups relating to CDH and point-of-care ultrasound. And with that, I'm going to hand the floor to Dr. Gopal and thank her again for her time, and I'm looking forward to what will be a great talk. Thank you.
Thank you, Liam, for that introduction. It gives me a lot of pleasure and happiness being here talking about a topic that's very near and dear to my heart. I want to kind of share that my journey and life in neonatology began with falling in love with the duct. Yes, that's a little bit of a controversial statement because do we all really, really like the duct? Not really. But my interest in neonatology started when I was working in a basic sciences lab, which dealt with PDA physiology in animal models. And when I started my fellowship in neonatology at Texas Children's, that's where I got a robust CDH experience, and that kind of piqued my interest in CDH in general. I was very intrigued by the use of prostaglandin infusion in these babies for pulmonary hypertension purposes, and that's what got me connected to a lot of researchers in CDH and has continued to inspire me to keep going and develop this as my niche for my neonatology career. So with that, I want to kind of thank everyone for this opportunity and thank you for your patience as you listen to me talk about all the different aspects of ductal dynamics in CDH. So my big objectives today are to kind of understand and review some of the CDH pathophysiology. We've heard a lot of lectures on CDH, and I think I'm just going to take a little portion of that to kind of introduce this topic of how and what happens in the CDH pathophysiology, specifically in the cardiopulmonary aspect of things. And then we'll kind of talk a little bit about the role of the duct itself, and I'm going to divide that into acute, pre-surgical, post-surgical management, and talk a little bit about ECMO and the role of the duct on ECMO as well. And then we all want to know a lot about alprostadil, prostans, or PGE infusion in CDH, which seems to be something that a medication that we've all known and loved for our critical congenital heart disease babies is now being used for pulmonary hypertension. And it has been used quite often in different aspects of pulmonary hypertension, but just getting a lot of attention of late. And then we'll kind of explore future directions on the role of PGE infusion therapy in CDH in general. So going into my first objective, where we'll kind of review the CDH pathophysiology and its general impact on cardiopulmonary physiology. We all understand and know CDH, and we know that CDH is a relatively rare disorder, most common on the left side, as you can see in comparison to the right, and the posterolateral hernias are the most common ones, but you also have an anteromedial type of hernia and a central tendon defect, each with its own severities and risk factors on and its impact on adverse outcomes in babies. There is a two-hit hypothesis that's been proposed for CDH, and in general, the first hit happens with genetic or environmental causes, and the second hit is basically because of that herniation of abdominal contents that causes not just an ipsilateral hypoplasia in the pulmonary vasculature and parenchyma, but also on the contralateral side as well. So these babies tend to just have poorly developed lungs to start with, not just on the affected side, but both on the unaffected side and the affected side as well. Now, when we kind of want to describe this fetal and postnatal cardiopulmonary physiology, the first thing that happens, of course, it starts right in the fetal life with abnormal pulmonary vasculature and parenchymal development. And this had been confirmed in obviously a lot of animal models, but also in autopsy specimens of babies with CDH, where they kind of compared the parenchymal development of the lung in these babies. And you can see this comparison, side-by-side comparison of normal versus CDH lung parenchymal findings, where you can see that babies with CDH can have really thickened alveolar septa and decreased airspace. And you can see that difference. And I'm not a pathologist, but you can clearly see that normal babies have a lot more white space. And with CDH, you can see that the airspace is so restricted. This is also reflective in the fetal vascular development, where you can see that babies with CDH can have medial thickening, intimal thickening, hyaline membrane formation, and they typically present with decreased pulmonary vessel branching, decreased responsiveness, all of which reflects in the postnatal life with increased pulmonary vascular resistance that we all very nicely know about. And when we talk about the lung development, we also have to pay attention to the cardiac hypoplasia that has been reported recently in the last decade in babies with CDH. And in general, this has also been reflected in these babies just presenting with smaller left-sided structures, with lots of reports showing features like hypoplastic left heart and coarctation of aorta being common associations with CDH babies, especially the left-sided CDH babies. And if you had to think about the pathophysiology of why that happens, well, first, these babies have that mechanical compression from the herniated contents from the abdominal cavity. The other aspect that also plays a role is that in general, within the fetal circulation itself, there's reduced pulmonary blood flow that happens because of vascular changes. And then finally, there's redirection of ductus venosus flow away from the foramen ovale. And so these babies just have a no flow, no grow kind of phenomenon with very reduced LV growth and overall basically presenting in the form of LV hypoplasia, which can indirectly be one of the causative factors for LV dysfunction that we can see in these babies. And then we all know about the precapillary PVR elevation. We are well versed with this, being trainees, being consultants, about how a nightmare of a patient can be a CDH baby, with how difficult they can be to manage with their pulmonary hypertensive crisis. And prenatally, these babies just don't undergo that pulmonary vasodilation and increase in pulmonary blood flow that we normally see with term babies. And as a result, these babies just can present with severe pulmonary hypertension right from the get-go. And it also begs the question if it's the lung that started the problem, or the heart that started the problem, or a combination of factors that played a role. And then there's the concept of RV uncoupling that also plays a pretty significant role in postnatal cardiopulmonary physiology. And I want to give credit to Dr. Morales Fernandez, a very good friend of mine, who helped me create these GIFs that you're going to see these different versions of these GIFs throughout my presentation, and I'm very grateful for her to bring my thoughts into my imaginations into a GIF format. But basically, what RV uncoupling happens is that initially, when the babies are born, they have sort of a normally reactive right ventricle that is kind of transitioning, but it undergoes dilation with this increased pulmonary vascular resistance and that increased afterload that the RV is facing, that eventually becomes hypertrophied RV as the duct closes and as this baby transitions. So you have this slow transition and slow uncoupling of the RV from the pulmonary circulation, which obviously is a big problem in these babies, and that's where this whole idea of pH crisis in CDH babies comes about happening. And then, of course, the ongoing importance given to the LV in these babies, and how the postnatal pathophysiology consists of LV dysfunction, which has been given so much of importance and so much of attention these days, which basically is a combination of both primary and secondary. In some situations, you would just have primary LV dysfunction, which can be in the context of that LV hypoplasia that can predispose these babies to LV dysfunction. With the placental circulation being cut off, there's increased SVR and generalized acidosis, which can all be pretty detrimental to myofibrils in these term babies. And then secondary LV dysfunction in the context of pulmonary hypertension and RV failure because of ventricular-ventricular interaction and reduced diastolic filling, and that septal bowing that can worsen your LV output that is coming in as well. And so this combination of these factors typically can present in the form of LV dysfunction, which, as I said, has been linked to a lot of adverse outcomes in CDH, thanks to amazing research done by some amazing CDH experts currently. I always say this, that no CDH talk is complete without this picture coming up in the presentation. And we've all been taught so wonderfully by some amazing CDH experts, such as Dr. Patel, on the different phenotypes in CDH. And we are aware about the first phenotype being a mild PH, or phenotype with minimal or no cardiac dysfunction, but typically a left to right atrial level and ductal level shunting. The pre-capillary PH phenotype, where there is right to left shunting both at the atrial level and the ductal level. And these are the textbook pulmonary hypertension babies, where the RV is dilated, the RV is failing, and the RV is facing such significant dysfunction and afterload. And these babies typically have obviously keep us all up at night with PH crisis and for lack of a better word, flirting with ECMO now and then. And of course, phenotype 3 are the babies that typically just don't even let you go to the call room, I would say. They would just want you to be at bedside all the time. These are babies that have a right to left shunting at the ductal level, but interestingly might have left to right shunting at the atrial level in the context of LV dysfunction. And so these are babies that have been given a lot more importance and attention. And with the ongoing evolution and advent of targeted neonatal echocardiography, there's a lot of recognition of this particular phenotype early. And as we all know, this is such an important recognition, because there are therapies in pulmonary hypertension that might be contraindicated or might be detrimental for babies if they do present with LV dysfunction. And so these different phenotypes, while have been reported significantly in CDH, are applicable to PPHN in general of different kinds. And I think that's something to apply them to different aspects of PPHN, including meconium aspiration babies, babies with neonatal encephalopathy, and any baby that might just be, just transitioning and having significant pulmonary hypertension. So going into my objective 2, where we'll be kind of talking about the role of the duct in general. And we all feel, when we look at a duct, I think that, it depends on which kind of baby you're looking at. If it's a preterm duct, you're like, oh, why is this pesky little vessel open, right? You just want that vessel to close. But in pulmonary hypertension, the duct does have a good role in helping support your management better. It does have a pretty significant role in understanding what is happening with the QP and QS indirectly. And so we all know that the duct plays an important role in our pulmonary artery pressure assessment. So the most common ways that we indirectly assess pulmonary hypertension in babies on an echocardiogram is ductal flow pattern, septal position, and TR jet velocity. Now, the ductal flow patterns are important because they kind of give an indirect assessment, especially if it's present, obviously. If it's not, then that's a big question in itself. But the septal position, we all have qualitative ways to look at it, but also a lot of centers have been advocating for end-systolic eccentricity index as a way to also assess septal position, which can give you an indirect evidence of how much afterload the RV is undergoing. And then the TR jet velocity is it's good because it gives you a way to calculate your pressures on the right side using the Bernoulli's equation. But as we all know, with RV dysfunction, that can be underestimated, and that has to be taken with a grain of salt. And so the duct is important for pulmonary artery pressure assessment, and we are currently doing a study where we're trying to look at, well, what exactly is out there in the literature. So this is just a snapshot of ways to assess pulmonary hypertension and ways that pulmonary hypertension has been defined in the literature. And this involved us looking into close to about 7,000 papers on CDH, and out of which about 113 papers were included. And we had basically looked at papers that actually defined how they used pulmonary hypertension and cardiac dysfunction specifically in the CDH population. Interestingly, only about 70% of them had an explicit definition for pulmonary hypertension in their methods section. About 40% of them referenced the definition that I'd shown in the previous slide, which basically included assessment of the septum, assessment of TR jet velocity, and assessment of ductal flow patterns. And as you can clearly see, the most common method by which pulmonary artery assessments have been reported in the literature is PDA flow characteristics, which is seen in about 70% of the papers, which I think it's an important segue to say that the duct is so valuable, especially in our pulmonary artery assessment and pulmonary artery pressure assessments. And so it's so valuable for us to know what what does the duct try to say, and what is the way we can apply that into our clinical practice and understanding how it impacts our overall outcomes. With that in mind, I kind of wanted to ponder upon, well, is there a way we can kind of come up with ductal flow-based hemodynamic patterns, especially in CDH? And again, this can be applicable for any baby with PPHN having a duct. And so going back to the GIFs that my very beloved colleague had created for me, so you have different ways by which the duct can inform you about what is going on between the QP and QS. And this is helpful. And the way I look at it is three different phenotypes. And the first kind of physiology that I think about is the duct balancing QP and QS. And so I describe that as a ductal balanced physiology in PPHN, where basically the duct is doing a fantastic job offloading the right ventricle. In other words, the duct is your friend, and it's actually doing a decent job offloading the right ventricle. It's having a pretty decent balance between right to left and left to right shunting. And these are babies that typically are okay. They are relatively stable. They do show some pre and post ductal gradient, but to a level that is manageable. And then you have the ductal restricted physiology, which again is in the context of PPHN, where the duct is kind of closing. The RV is under significant afterload. There is significant RV dilation, and there's limited shunting at the duct level. And these are babies that typically personally keep me up at night because the duct is just not doing what it's supposed to, and the RV is failing. And obviously the patient is not probably going to be doing well clinically as well. And so this is a very interesting physiology which needs to be getting a lot of attention and a lot of quote unquote catch earlier rather than later. And we'll talk a little bit about how PGE can help in these situations as well. And then the third kind of phenotype is one where, the patient has had that acute phase, and if the baby is a CDH baby that we're talking about, has undergone repair, is doing great, the RV is recovering. However, this baby is just continuing to remain on the ventilator, continuing to require oxygen. And this is this ductal steal physiology that I think about, where the duct is wide open in these babies, and these are the typical preterm ductal physiology where there's ductal steal happening. And these are term babies. They're not supposed to have a duct for too long. And obviously that can cause pulmonary congestion, that can cause ductal steal from the systemic circulation. And this can indirectly also lead to volume mediated increase in PVR. And so these are babies that also need quite frequent assessments despite going through that acute phase, going through surgery. I think it's important to keep assessing them because the duct can become a problem later on. And just as we know in hemodynamics, there's not one particular physiology that's going to be present throughout, and that's the emphasis and the reason why we have to keep assessing these babies. They might start with a ductal restricted physiology and go into a ductal balanced, or start with a ductal balance and go into ductal restrictive physiology. And ultimately, it's still important to monitor these babies' duct because it could potentially be a problem later on in the form of a ductal steal physiology as well. So now that we kind of talked about different ways that I personally think about the duct and the ductal-based physiology, I wanted to delve into the literature to understand, well, what's out there on ductal flow patterns. And in the next couple of slides, I'm going to try and see and kind of summarize what the ductal flow patterns would do in the acute, in the pre-surgical, and in the post-surgical phases. And so first, going into early ductal flow patterns in CDH outcomes, there have been pretty good about 4 papers here that have done a very good job in kind of summarizing what does the early ductal flow pattern tell you, and how does that reflect to overall outcomes in CDH. And all four papers had looked at the ductal flow patterns within the first 24 hours of life. Of course, some of the papers had looked at them earlier, and they looked at outcomes, more commonly ECMO and mortality, and all of them consistently said that the right to left shunting at the ductal level, early right to left shunting at the ductal level, is associated with increased risk for ECMO and mortality. Now, some of you reading this might be like, well, yeah, that's obvious, right? Because pulmonary hypertension, yeah, of course, pulmonary hypertension is associated with worse outcomes, but it's just that's the importance I'd like to give to the duct, because if you see a right to left shunting that's that early, it probably reflects that this baby's physiology is going to be a little difficult to manage, and these babies are at pretty high risk for ECMO and mortality. I'd also like to kind of focus on the measures column that we have here, where you can see that different ways of monitoring the duct here. And there are a lot of the most common ways by which people do this is just qualitatively assessing, well, which direction is the Doppler flow going. But interestingly, this particular VTI ratio, which I think is pretty common in the hemodynamics world, is such an important way to kind of understand that balance of right to left versus left to right shunting, which gives you a lot of information on how quote unquote balanced or restrictive the duct is in the context of PPHN. So just some interesting data out there on its relation to important outcomes in CDH. We recently had a very fantastic talk by Dr. Patel on hemodynamic assessments for surgical timing, and that got me interested to see, well, what is out there on ductal patterns and surgical timing. And interestingly, there have been a few papers, at least three papers that you see here, that have looked into looking at protocols where they decided on surgical timing based on ductal flow pattern and ductal size. And interestingly, all of them showed that they were associated with good outcomes if the duct reversal was seen, meaning that if the ductal flow pattern had reversed from right to left versus left to right, and they had planned a surgical timing based on that, that was associated with good outcomes. And those with right to left shunting had poor outcomes overall. And there was a study in 2021 by Shino et al. that had put out a protocol based on the VTI ratio, basically, and the protocol group had shown shorter duration of ventilation and earlier surgical repair in those babies where the LR ratio was greater than 50%. So just some interesting data on utilizing ductal flow patterns in decision making for surgical timing, which is an important factor as well. This wonderful review article by Dr. Wren from Iowa had summarized this this is a very good summary of how we could think about surgical timing based on different aspects of CDH phenotypes. I think A, B, and C are common phenotypes that that has been described in the literature as being precapillary versus postcapillary pulmonary hypertension, and you can see that the PDA shunt has been taken into account in this particular picture. But what got me interested was was picture D here, where there is a problem when you continue to wait, and if you continue to wait, that flow is gonna switch from right to left to right, and there might be flow mediated pulmonary hypertension that might impair appropriate repair time, and that delay can cause adverse outcomes in these babies. And so I think it's an important factor to take into consideration, especially in CDH, where with the RV dysfunction, the TR may not be as reliable, and the septal position might also be very subjective if you're only taking into account qualitative septal assessments. If you've not paid attention to anything that I've said so far, this is the summary of what I was saying. So this should work. And what I think is important, and a summary of the data that's out there, is that early left to right shunting is kind of reflects a slightly balanced physiology, but early right to left is more concerning. And as that flow reversal happens between right to left to right conversion, the risk of ECMO decreases over the period of time. So dominant right to left flow in the early period can increase your ECMO risk. And as that reversal happens, and as there is a more left to right pattern or bidirectional pattern, the stability increases, and that has been reflected in all of the existing literature and evidence as well. So this got me interested to think, well, what about ECMO? Obviously, CDH has such a big patient population with significant risk for ECMO. I was curious to see, well, what exactly happens when a baby goes on ECMO, and what if the baby has a large duct that's present and that's actually kind of offloading these babies? And so not specifically in CDH, but there have been studies specifically done in newborns with pulmonary hypertension. And this particular study actually was a case series of their patients, and they looked at VV ECMO. They reported that having that duct open is helpful in that early phase as babies transition on VV ECMO, from the standpoint that it helps to offload that right ventricle as the right ventricle is getting supported throughout your VV run, but then once that transition happens, once that switch happens from right to left to right, that's when things can be pretty harmful if it stays persistent. And if there's a persistent left to right shunt on ECMO, that can be associated with difficulty in weaning and adverse outcomes such as pulmonary hemorrhage. And they had this very interesting sort of picture of their case series, and they had reported that all of their patients showed complete reversal of the PDA shunt from right to left to right within about a day, a median of 1 day from ECMO run, which is kind of obvious because we are transitioning these babies into an ECMO circuit with higher systemic vascular resistance, and therefore that reversal does happen. But what's also interesting is that the report had some of their babies that had spontaneous closure, but about 4 of their babies required pharmacological closure and 8 of their babies required PDA ligation. Out of the 8 babies, the 6 of the babies actually had the PDA ligation on ECMO just because the duct was such a menace that they had to close it while on ECMO. But there were couple of babies, the 2 other babies that had undergone the PDA ligation had to wait until being decannulated because the duct was indirectly helping them getting off of the ECMO, and then they went on to undergo PDA ligation thereafter. So just some interesting patient-related factors that might play a role on timing of closure of the duct, if you will, in this patient cohort as well. So if you had to summarize VV and VVA ECMO, and there are a couple of articles on ductal shunting patterns on VA ECMO as well, but the pattern is pretty straightforward. So if you do have a flow reversal that happens in the early phase, that sudden change in the shunt can be harmful in terms of increasing risk of pulmonary hemorrhage. And if it stays persistently right to left, there can be situations where you might have to intervene, and the intervention is more from the standpoint of difficulty in weaning or having persistent left to right shunt that's just not helping you with your recruitment overall. So going now into the post-repair phase in a baby that has undergone all of the drama of initial clinical management, going through all the clinical acute pulmonary hypertension crisis and everything, what if the duct is still open? Well, is that a problem? Like, is the duct okay to remain open like that, or should these babies even be bothered? And that got me interested to understand and kind of question, is the duct truly a friend in all situations? And so that is where this whole ductal steal phenotyping came into place, where if you have an open ductus and there's predominantly left to right shunting, there's increased pulmonary congestion in an already underdeveloped, maldeveloped, and maladapted pulmonary vascular bed. And this can increase your pulmonary vascular resistance, which is a flow-mediated pulmonary vascular resistance. And this phenomenon is quite commonly reported even in the BPD population, where babies with BPD, they just have problems with ventilating and oxygenating appropriately if they have a large duct that's present. And that is also kind of reflective on the presence of ASD, for example, in BPD babies as well. So that's where this whole idea of ductal steal phenomenon in these babies comes about happening. And that got me interested as a fellow, where I wanted to look at, well, what is the association with the timing of an open duct with outcomes in CDH? And so we looked at 2 different time points, 14 days of life and 30 days of life. And we wanted to look and see if these babies, when they were adjusted for their severity, had any change in their outcomes. And interestingly, all of these babies had increased need for pH medications, increased need for diuretics at discharge, longer length of stay, and longer duration of mechanical ventilation, both if they had an open duct at 14 days and 30 days of life, which I thought was very interesting. So now that we've kind of talked about the duct and how that pesky little vessel has both roles of being a friend and a foe in every way possible, let's delve into this topic of PGE. And PGE is the medication that got me truly interested in CDH. And I think all of us want to know a little bit more about PGE because there's such limited evidence out there, and there's still a lot of centers that practice it routinely. So I think that this is a good way to kind of understand how PGE can be helpful in pulmonary hypertension. But let's review how and what's out there in PGE. So PGE in general, we know that it's a vasodilator and it has a direct effect on the vasculature and smooth muscle of the ductus arteriosus. There's various dosing ranges that you can start with, but about 60 to 80% of PGE is metabolized in the lungs, and the effect can happen within about 30 minutes to 2 hours, which is such a big advantage in especially in smaller NICUs where you are dealing with a critical congenital heart defect, that you can start PGE and safely transport these babies to a higher level of care. And we know that PGE in neonatal population can be used in severe restriction to pulmonary blood flow, severe restriction to systemic blood flow, and anomalies that require mixing. But that begs the question, what about functional obstruction? Which is where, we all are curious to know how advantageous it could be for the use of PGE, specifically in PPHN, and in my case, in CDH. So this got us interested to write this review article back in 2022, where we delved into this topic of PGE use. The common mechanisms by which PGE can be helpful in babies with CDH is, well, firstly, it can cause afterload reduction. It keeps that duct open, so it changes these babies from having a ductal restrictive to a ductal balanced circulation, and so it makes it very easy for that right ventricle to recover, and if it's dilated, to kind of take that pressure load off of that right ventricle. In the process of doing that, it also augments systemic blood flow through the aorta in the setting of LV failure. And one of the biggest advantages it also has is it's a direct pulmonary vasodilator. And so since we're dealing with babies with significantly elevated PVR, this can be helpful in this situation. And of course, we had to dig hard to see what does the evidence actually say. And currently, there are 5 retrospective studies, all observational studies, and about 4 case reports. This is just a summary of all these studies that are out there specifically on PGE and CDH use. And the first couple of studies that were done were out of Japan. Inamura et al. Had 2 studies with similar criteria for starting PGE in his patient cohort. Basically, they started PGE based on the duration of right to left shunting via the ductus. So if the duration of right to left shunting was longer than the left to right shunting, they provided PGE for their patients. And initial paper in 2005 had looked at diastolic performance, which included parameters such as LV diastolic diameter, total pulmonary artery index, LV myocardial performance index, and all of that improved with PGE use. And he went forward to look at additional markers of LV function, and all of that showed improvement with PGE use as well. Shianagi in Japan also looked at PGE use in his CDH cohort, where basically they divided their patients into those who received INO with and without PGE. They reported no significant difference in survival, but slight improvement in pulmonary hypertension on their echocardiogram, which went forward to Lawrence et al. From the US, where they had looked at their PGE use in their CDH cohort and had specifically looked at pulmonary artery pressure assessment on echocardiogram and plasma BNP levels. And we all know that plasma BNP is basically a marker of LV strain, and or I think it's a marker of LV strain, but the only issue that is that you don't know if it's RV or LV. So it is just a marker of wall stress, if that's an easier way to describe it. So an indirect assessment of whether the LV or the RV is in significant stress. They started PGE in their babies based on echo findings of pulmonary hypertension with the restrictive PDA, but also took into account clinical parameters such as metabolic acidosis and postductal arterial oxygen content of less than 30. And so when they reported their literature, they found that, as you can see, the BNP level had come down and was statistically significant. And they had looked at their pulmonary artery pressure assessment based on shunting pattern of the duct, based on septal position, and TR jet velocity used to estimate your RV systemic pressures. And they found that they all had significantly improved post-treatment with PGE. Finally, most recently, Leduc et al. From France had done a study on PGE use in CDH, and they had looked at various oxygenation parameters, and their criteria for starting PGE was an increase of more than 20% of FiO2 to target a preductal SAT of above 88% and signs of circulatory failure. And when they had looked at their data, they found improvement in FiO2 requirement. Their data specifically only showed the trends in 72 hours of life. So they probably kept it longer, but then the report specifically only talked about 72 hours of PGE use, which, as you can see, within a course of 72 hours, the FiO2 improved, and there was also improvement in the PDA velocity after starting PGE as well. So that kind of went on to kind of understand, well, there are centers that are using PGE. There are centers that have been having specific criteria. So I just wanted to delve and see, what do our international consensus guidelines say? So the European consensus guidelines had a statement on PGE use to start PGE or to consider PGE in situations of suprasystemic pulmonary artery pressures and right to left shunting through the foraminal veil. The Canadian guidelines had specific PGE use specifically for CCHD babies, but also use of PGE could be considered in the presence of suprasystemic RV pressures and in the presence of RV failure, and if the right to left ductal shunting exceeds left to right ductal shunting. And so those were the two international consensus guidelines that had some mention of PGE. A recent pharmacological review on CDH that was published in your reviews had a mention and had a section specifically about PGE, and the criteria that the experts had mentioned for considering PGE were systemic or suprasystemic pulmonary hypertension, moderate or severe RV or LV dysfunction or RV dilation, and a constricting or a closed ductus. And in the parentheses, they had suggested that if the duct is open and it's already patent, PGE may not be required, which I think also reflects most of our practice as well, but something to consider as what our international guidelines and our experts suggest. Now that we've talked about kind of the PGE in its acute phase again, I wanted to check if there is an evidence for PGE use on long-term outcomes. And interestingly, there is this study that came out recently from the Children's Hospital Neonatal Consortium, which is CHNC. It's a large network in the US with multiple hospitals submitting their data on different kinds of pathophysiologies, one of them being CDH. And in this study, where they looked at treatment of pulmonary hypertension during initial hospitalization, in their table, they had mentioned PGE use, as you can see, which was reported in about 15% of their population. And one of the things that they reported, that survivors discharged home on PH medications had a higher exposure to PGE in comparison to those that went home without PH medications, which again was an interesting observation. When we looked at the duration of PGE therapy, you could see that it was an average of about median of about 7 days. It was not statistically significant between those who survived and were discharged home with and without PH medications. And when we think about when the PGE was started, it was overall started within the first day of life. And again, no statistical difference between PGE's initiation time between those who got discharged with and without PH medications. Just an interesting thought, but I think what caught my attention was the 15% use in the CDH population. The CDH study groups has about 11% of patients that have been exposed to PGE, which again is an interesting report. But also, I'm pretty sure that if we had to look at the data today, that might be a lot different and a little higher, because a lot of the centers, like I said, are implementing more PGE use, more early recognition, and more common use of PGE in CDH. So going into my final section, where we'll be kind of talking about exploring future directions on the role of PGE, I think I want to start the section by addressing the big elephant in the room, right? Should we consider PGE like a critical congenital heart defect, and should we actually be considering prophylactic PGE in these babies? And again, had to go into the literature to look and see if there's any reports of that. And actually, the study that I had mentioned previously, Ductal et al., that was one of the 5 retrospective studies that had looked at PGE use in CDH. There was a table, or there was a small cohort of 16 babies where prophylactic PGE was used. And the criteria was just based on consultant discretion, based on the report. But interestingly, compared to PGE rescue treatment, babies that had received PGE prophylaxis had actually reduced duration of mechanical ventilation and reduced oxygen exposure, which I think was very interesting. And this was the first report on any form of prophylactic PGE use back in 2020. another study that came out recently was by Bird et al. And this was a study out of Baltimore, Johns Hopkins, Baltimore, where they had compared babies who had undergone sort of an upgrade of their guidelines, and they had updated their CDH guidelines, and there were multiple changes that happened in their guidelines, as you can see. But one of the changes that also was implemented was starting PGE empirically to encourage PDA right to left runoff or RV output. About 77% of their cohort had received PGE in their population, and the overall report said that there were reduced rates of ECLS cannulation, ventilator days, and INO utilization, which I think can be attributed to multiple factors, but just an interesting observation that these babies were actually started on PGE earlier and empirically as well. Some new and upcoming data. I want to take this opportunity to thank Dr. Weems for sharing his unpublished data here. So this was a poster that I recently came across at the CHNC meeting, and this was a study looking at routine prostaglandin therapy in their CDH population. Their protocol would start PGE on every CDH babies and would kind of de-escalate the therapy after the first echo to a lower dose. And they would keep the babies on PGE post-repair. After the repair, if the babies develop left to right shunting, they would stop PGE. And after post-repair, if the shunting was still bidirectional, they would continue PGE for 2 more weeks. So the median duration that they had suggested was about 9 days. They reported non-significant improvements in death and ECLS, and they reported significant reduction in INO utilization in the first 72 hours. But interestingly, they also reported increased duration of mechanical ventilation. Now, I would say that based on the demographics, it seemed like the babies that had worse pulmonary hypertension received PGE. So it's unsure and unclear if PGE use itself maybe increase the duration of mechanical ventilation because of the ductal steal phenomenon versus just babies having bad lungs to start with. But it's just an interesting report and something that's going to be up for publication soon as well. So then that brings another question. Would a predefined targeted neonatal echocardiographic criteria be helpful? And should these babies be assessed a lot more often to kind of see when that flip of physiology happens, and if these babies can be recognized earlier and started on PGE earlier in order to help with offloading that right ventricle or the failing right ventricle? And so I want to take this opportunity to thank Dr. Livenkoff, who had gracefully agreed to share some of her data. She's from the Royal Children's Hospital at Glasgow. The criteria that the group had reported to be using is RV dysfunction with or without dilation, systemic or suprasystemic pulmonary artery pressures, and a constricting duct. And they basically compared babies who had received PGE versus who had not received PGE in their first echocardiogram. And the second comparison was PGE recipients versus non-recipients just prior to starting PGE. And they continued to look at the PGE recipients throughout their course of how their hemodynamics changed. And so the first thing was that the PGE recipients, just like the previous cohort, had lost a lot worse CDH characteristics, pH markers, and RV and LV dysfunction. And PGE use in their cohort that had received PGE had showed improvement in RV and LV longitudinal strain and reversal of PDA VTI. And despite starting out pretty severe, there was no significant change in ECMO and survival, which is such a big and optimistic message that the group will hopefully provide on use of PGE in the CDH population. So some of the graphs that they gracefully shared, and as you can see, the PDA VTI had kind of swapped from right to left to right, and the LV and RV longitudinal strains had improved in babies that had received PGE. So then that brings this question of, well, can we think about a ductal physiology-based algorithm for initiating PGE in these babies? And I think that starts with early, appropriate, and frequent measurements of their hemodynamic patterns. And the way I think about it is if the baby has a balanced circulation right from the get-go, and if you continue to see that even pre-op, I think it's okay to observe these babies, especially if they have a duct that's doing a good job of balancing QP and QS. Various ways to measure it, but VTI seems to be a good way to kind of assess that in a good fashion, a right to left, left to right VTI. And then if you think that the baby's VTI is getting abnormal or the size of the duct is getting smaller, I think it's fair to consider PGE in this patient population. And of course, if the baby starts out to be restrictive, then that might be your candidate for PGE. And what I mean by restrictive here is a dilated right ventricle, significant pulmonary hypertension, and a duct that's closing off and duct that's just not doing a good job. And then, of course, very rarely you would see any kind of steal in the first 24 hours of life. It's so rare that you would ever see it. But if the baby does show a steal physiology of left to right shunting with a large duct on ECMO or post-surgery, I think it's fair to say that it would be appropriate to stop the PGE and see if the baby's duct closes off naturally. But if not, that might be a baby for an intervention and to consider if the baby would benefit from that duct being closed off. So we all would love to start PGE use, and we would love to know a little bit more about how it would impact our outcomes overall. But we still have so many things to kind of delve into, like indications, for example, like which is a good baby that could benefit from PGE. And I think the answer to that is always early assessments, frequent assessments, and understanding which phenotypes that these babies fall under. And of course, there are questions on dosage and duration, how long and how much is appropriate for babies. And obviously thinking a little bit about the adverse effect profile of PGE too, because PGE does cause hypotension. It can be associated with some long-term side effects such as hyperestosis and gastric outlet obstruction. So it's important to take those factors into consideration too. And yes, we all would love to have timely assessments, but we're still living in, a lot of hospitals are still living in the early phase of their hemodynamic teams. And so it might be challenging to get timely and more frequent assessments, but also these are babies that I think you might have to assess them quite frequently because we don't want that physiology to have significant changes and have adverse outcomes on babies. And also, once we change and once we kind of monitor, it's also important to delineate what and how to monitor these babies. While we all want a beautiful randomized control trial to answer all of these questions, we all are quite aware that with CDH that can be challenging. And this is a very fantastic article that kind of delineates challenges and pitfalls of performing randomized control trials in babies with CDH. And as you can see, there's been 4 trials that have been complete in all of our years of knowledge about CDH, and maybe one more trial that's been added into complete trials in CDH. And I think this is such an important information to kind of realize, because I think we all want good outcomes for our babies in CDH. CDH is a rare disorder, and I think the most information you can get is from amazing national and international collaborations, which I'm personally grateful for because I've learned a lot throughout my career on understanding CDH physiology from so many wonderful experts around the world. With that, I would like to end and open the floor for questions. I hope the duct it gets you a lot more curious after this talk, but I'm excited to hear more and answer your questions.
Thank you, Dr. Gopal, for a fantastic talk. I'm going to introduce Dr. Neil Patel and Dr. Mamu Montas, who don't need any introduction. They're both our chair and vice chair of the NeoFOCUS group. I welcome any questions. If you could place them in the Q&A box, that would be fantastic. But yeah, I'll hand the floor to both Neil and Mahmood.
Thanks very much, Liam. Thank you, Rupa. Just an amazing presentation. I love the way you took us through I suppose, the different dimensions of the PDA and CDH. I think it's such an interesting topic. It totally deserved its own talk in itself, and you gave that absolutely brilliant justice. I've got quite a few questions. I'm sure other people will as well. Maybe I can abuse my position on the panel to start with the questions, if that's okay. So I was really interested in your thoughts about, you highlighted for us the changing role of the PDA in CDH and the importance of, I suppose, functional echocardiography and having a direct window onto that changing role. But you also commented, particularly towards the end of your talk, about obviously the challenges of availability and access to echocardiography as often as we might want it in these babies. So I suppose I'm interested in what your thoughts are about what would be the general practical advice to a centre that had limited access to functional echocardiography based on the existing evidence you've summarised for us to date. Should they, in the absence of echo, not even think about using prostaglandin to maintain the duct? Should they have one of those empirical approaches to use of prostaglandin? Or do they need to just work on developing their hemodynamic team or befriending their cardiologists to get that regular functional echo assessment? What do you think?
That's a fantastic question, and I think I think if I had one answer to give you, that probably would be the third option, that it would be appropriate to have a hemodynamic team for early and quick assessments. Now, is that practical? Is that going to be logistically appropriate? I think there are going to be challenges with that. And I think that, like I said, we're living in this world of evolving hemodynamic physiology and evolving hemodynamic training in all centers. Everyone wants to have a hemodynamic program, but there are challenges and logistical and practical, your pitfalls to go into and like loopholes to go into. But what I think for babies who, for lack of a better word, I really don't believe in this honeymoon phase, but I do think that there are babies that kind of behave well and start out clinically fine, and then they have a phase where they crump. And I want to kind of share this memory of fellowship where the day that a CDH baby is born is actually the best night call you could have, because nothing's going to happen. The kid's going to be fine. They're going to be okay, unless the babies have bad markers to start with. It's the day after that's a problem. It's the day after where, as a fellow, you're going to be at bedside trying to figure out what's happening. And, yes, there is a description of honeymoon phase, but in my mind, that's the phase where your duct is kind of closing. And I think that having that early assessment within the first 12 hours, if that's possible, is helpful to at least know what the duct is doing. There's such limited evidence out there in the literature on timing of echocardiography in CDH. There's just such limited evidence on that. And places that have hemodynamics do it earlier and have shown pretty good outcomes with that. On the contrary, there are centers that have just lay their hands off of doing any echo and rely on fetal echo and have also shown good outcomes. So I think the balance there is that if these babies are having significant pulmonary hypertension crisis, it is okay to blindly start these babies on PGE. It is a pulmonary vasodilator. It is going to be helpful if the duct is closing, if that is a potential physiology that your pre and postductal sats are giving you. And I think that clinically, if the baby is worsening, it is okay to start these babies. But I think that once you start it, I don't think you can get away without monitoring the duct. And I think it's important that you would have to not just monitor after the PG is started after 24 hours, but it needs to continue on, because we have to monitor these babies' duct reversal, and the shunt reversal can have detrimental effects on their physiology. So if I had an answer to give you, it would be one, hemodynamic assessments, frequent hemodynamic assessments, earlier the better, to give you a little bit of idea on how the duct is doing. But if you don't have that, you can start PGE, knowing that you would have to have a follow-up echo and understand what's happening there.
Thanks very much, Rupa. I think that's really great practical advice, definitely. The other thing you touched on at the end was the challenge of randomized controlled trials in CDH, and whether this is a topic that even is studyable by RCT. Do you think it is? I'm really interested in your thoughts.
Oh, no. For people just sharing something, I feel like the first time I met Neil, that was my first proposal. I was telling Neil, I don't know if Neil recalls this, but as a naive first year fellow, I was like, I would like to do an RCT on PGE use. And it was the funniest memory I have, because now I can think about how challenging that can be. And, now moving on in my career, I understand how difficult that is. I think that RCTs in CDH in general are challenging, and they are challenging not just because of how rare the disorder, but yes, that is one of the big factors. But second, I think that management of CDH is quite heterogeneous. We've seen this in our current study that we've undertaken, that definitions of even pulmonary hypertension and cardiac dysfunction, as I've shown in my slide, is quite variable. So they are just heterogeneous to start with. So can we study PGE use in CDHs and RCT? That's a big challenge to have. Is it impossible? I don't think so, but I think that it's going to be challenging because there's such significant heterogeneity between between places and between patient populations, and the consent rate is going to be extremely sparse because parents, as we all know, are quite stressed just having a baby with a diaphragm defect. And so trying to convince them about a medication that may or may not work, that may or may not, have significant outcomes and has such limited evidence can be challenging. So from the practical standpoint, it has its challenges. Do we need an RCT like that? I think we've known that we've had such significant CDH literature with retrospective studies and international collaboration. So I think we can continue to do that. But if it were to happen, I think it would have its challenges for sure.
Yeah, I totally agree. I loved your enthusiasm though when you first suggested it, and the best ideas come from people with a fresh look at things. So I don't think we should ever put the idea completely to bed. Definitely, yeah.
Oh, it's still there. It's living in my
Uh,
drive. So
Thanks, Rupert. I've just got a comment and a question, if that's okay. And just remind people if they want to put some questions as well for Rupert. So I couldn't agree more about the RCTs. I think it's very challenging in sick babies with hemodynamic instabilities, and we've seen that in the Merinon trial. It's really challenging, difficult to recruit. But back to the question that Neil asked about should we have hemodynamic team for centers who are looking after CDH? And my answer is absolutely yes. I don't think a center who would look after CDH patients who are the most sick, the most critical, and for potential ECMO, they cannot get away without doing, this kind of assessment. And because hemodynamic physiology changes as well from 1 to 2 to 3, phases. And it's interesting to look at the phenotyping of or the the hemodynamics of ductal pattern in CDH. But have you thought of combining PD dynamics with the intraatrial shunting dynamics as well to give you more kind of information about what kind of physiology and phenotype?
yeah, absolutely. I think that's a really good way to look at it, and I think that's our initial phenotypes that were provided by experts like Neil took that into account, and I think that the atrial level shunting is so important. Once the paper on the phenotypes came out, I think a lot of people paid attention to the ASD level shunting, and it became almost a little bit of a trend that everyone was very curious about the ASD level shunting. But I think the way I look at it personally is it's the LV dysfunction that has to be given a lot more importance. It's the LV dysfunction that's causing that left atrial hypertension. And so I think that the atrial level shunting plus ductal level shunting is an interesting way to look at it, and definitely something that I will ponder upon too. Thank you for that.
Thanks. We've got some questions here. I think there is one question asking about do you use empirical PGE1 in your center, or do you use it just guided by echo?
So no, we do not use empirical PGE. No, we didn't use that in my training. We don't use it currently. I think empirical PGE is currently being used in some centers. I know that Johns Hopkins presented their study on things that have changed in their new epoch after their guidelines were implemented. And empirical PGE can be considered if you feel like you are going to be getting an echo soon. I think that is fair, especially if you have a baby with very poor prenatal characteristics. I think it's fair to start these babies on PGE, knowing that they are going to be requiring frequent monitoring and echo.
Okay, thanks. I've got another question until we have some more, if that's okay. So in terms of just combining your talk with Neil's talk, and I'm just thinking, is there any specific PDA dynamic pattern you would go and say to the surgeon, hang on, you cannot touch this baby just now. You have to wait until something happens.
Yeah, no, I think that there are different ways to look at you're asking specifically about assessments, because I know assessments can be challenging for babies because as we all know our loving little babies with CDH just don't like being touched, disturbed, or anything. And the minute you even open the door, they can have a pH crisis. And there was a very common term that one of my loving attendings during fellowship used to say, that you're going to put a baby from echo to ECMO. Which is kind of an interesting analogy to think about. But, there are centers that have a more conservative approach on to like doing too many assessments and too much of assessments. I believe there was a study that came out from Utah, if I remember correctly, that had specifically talked about, is an echo necessary in these babies? Is an early echo truly necessary? And they actually showed pretty good outcomes in their cohort based on that. But you're going to have believers and non-believers on early assessments, but I think that it is what you do with that information, not just getting it, but also what you do with that information too. So yes, to your point, there you can disturb the baby, but if it gives you helpful information on helping the baby, I think it's important. And we all have sedation, we all give sedation, we all give neuromuscular blockade. I think it's good to like calm them before we do our assessments.
Thanks.
Thanks so much, Rupa. There's another question and comment, I suppose, from Marjorie in the Q&A, who says your talk highlighted that CDH care should shift from an oxygenation index-driven model to a phenotype-driven hemodynamic model, integrating duct directionality, ventricular performance, systemic output. And she's asking the question, what barriers are preventing this transition? I suppose it's a transition in the approach to management. We maybe touched on that a little bit already, but I don't know if you want to expand on that.
Yeah, no, I think we touched on it on having a hemodynamic focused model. I think that I've come to sort of an understanding, a personal professional understanding, I would say that CDH is, for me, in my mind, primarily a cardiac issue. And I think it's pulmonary hypertension, but it starts with the cardiac issue. And so I think if it's a cardiac issue, treat it like a heart condition. You would need an echo and you would need it early and you would need more frequent ones. Yes, do we have to ignore the lung for that matter? Well, no, but I think that the heart has to be given as much attention as possible because it's the heart that's causing the hypotension. It's the heart that's causing all of these systemic oxygenation issues. And so I think it's important to take that into consideration. In terms of barriers, I think the major barriers that we have is just not having enough assessment opportunities for assessment, enough personnel for assessment, and we all love our cardiologists, and they're not present around the clock in all the centers. They're not present with. We don't have sonographers present all the time around the clock, and to have a person just on standby for an assessment every 3 or 4 hours can be challenging unless you have a hemodynamic trained person in the hospital. And so you do have challenges from that standpoint. I think that as hemodynamics gets a lot more attention in the neonatology world, we are all going to have a need for early assessments and that support from the institution as well.
Great, thanks very much, Rupa. I think you're right. There are practical challenges, there are educational challenges, there's the mindset of understanding the physiology as well, isn't there? And there's still big gaps in our knowledge, I suppose. There's still I personally think still a really important role for ongoing observational study to understand how these babies can behave and how the different phenotypes can behave. Some really great complimentary comments. Excellent talk, Rupa. Perhaps the last question from Jan Clausen. In patients who do not show improvement in PPHN and their pulmonary hypertension despite optimal management, do you do surgery on ECMO? So I suppose the question is around, if a patient is going on ECMO, do you repair them on ECMO, or what's your approach to surgery?
Yeah, no, I've been trained with being comfortable with surgery on ECMO. So I came from a center where we did surgery on ECMO. I know there are centers that wait until the baby's stability is better coming off of ECMO after doing it. But I think that if the defect is causing the baby to have cardiopulmonary physiological challenges, then I think considering repair on ECMO is important, be it the actual CDH repair or a surgical ligation of the PDA in this situation. So I just want to first of all understand what surgery we're talking about, but either one, I think if the baby needs it, the baby needs it. What are your thoughts, Neil? How does your center function from the surgery on ECMO standpoint?
Yeah, thanks for throwing the ball back at Rupa. Well, I suppose the practical reality is that we're doing a lot less ECMO and CDH, and that's a consequence of a combination of changes in practice. As you showed, there are other centers who have also seen a reduction in their ECMO rate with changes in their management approach that is incorporated, I think, a hemodynamic guided management approach along with advocating for more gentle ventilation strategies. And I think the two go hand in hand, because the more we understand, as you said, this is a condition that has a very strong component of being circulatory driven, that's giving us the confidence not to turn the ventilator up and try and treat it as a respiratory disease. And I think we're protecting the lungs better that way. So that's, I think, part of the reason why we're seeing a lot less ECMO in our patient population locally. When we did have more patients who received ECMO for CDH, we, like many centers, had evolved towards an earlier repair strategy for the practical theoretical benefits of, first of all, just helping to get that the space for expansion of that hypoplastic lung and removing any mechanical impact of the hernia on the heart, as a means of then working towards weaning ECMO support and getting the patient off. And I think that was reflected in the most recent analyses from the CDH study group looking at timing of repair on CDH. It was a recent paper led by Dewey Dow that showed that. The other, I think, motivating factor, though, for this was an understanding of why patients went on ECMO. What was their underlying hemodynamic phenotype, including the role of the duct, that led to them to require ECMO? And if it was patients who had, severe biventricular dysfunction with severe pulmonary hypertension plus evidence of very impaired gas exchange, then yeah, they're the patients who you kind of think early repair, because how else are they going to progress? But for the ones who had more of a picture of severe LV dysfunction, and perhaps were going on ECMO for hypotension, oxygenation failure secondary to that, we kind of identified that they were a group that might have rapid recovery on ECMO and then wean to come off quite quickly before repair. But I think that's a strategy that's yet to be proven. And as I said, we're now unable to prove it because we managed to avoid ECMO in many cases.
Well, thank you. There were some excellent questions. I love that talk, Dr. Gopal. I think the idea about phenotyping and hemodynamics is fantastic, and I really loved some of the stuff that you went into there. Thanks, guys, for moderating as well. And we have our next session on I'm going to get the date right here. It's the 19th of December. We've got our last NeoFOCUS seminar for the year before we start in January. But just want to send my thanks to Dr. Gopal for a fantastic session today.
My pleasure. Thank you so much.
Thank you for watching. If you enjoyed this, please check out the other webinars on our channel.